Today we are going to discuss about Leflox, which contain levofloxacin. Levofloxacin comes in pack of 250 mg tablet, 500 mg tablet, 750 mg tablet and 500 mg intravenous infusion. Description: chemically, levofloxacin is a synthetic broad-spectrum antibacterial agent. Chemically, levofloxacin, a chiral fluorine carboxyquinolone. Clinical pharmacology. Mechanism of action. Levofloxacin is the L-isomer of the racemate, ofloxacin, a quinolone antimicrobial agent. The antibacterial activity of ofloxacin resides primarily in the L-isomer. The main mechanism of action of levofloxacin involves the inhibition of bacterial topoisomerase 6 and DNA gyrase enzymes required for DNA replication, transcription, repair, and recombination. Levofloxacin has in vitro activity against the following gram-negative and gram-positive microorganisms. It is often bactericidal at concentrations equal to or slightly greater than inhibitory concentration. It is generally considered to be about twice as active as its isomer, ofloxacin. Microbiology. Levofloxacin has been shown to be active against most strains of the following microorganisms both in vitro and in clinical infections. Commonly susceptible species: aerobic gram-positive bacteria. Staphylococcus aureus methicillin susceptible, Staphylococcus saprophyticus, Streptococci group C and G, Streptococcus agalactiae, Streptococcus pneumoniae, Streptococcus pyogenes. Aerobic gram-negative bacteria. Burkholderia cepacia, Eichnella corr odens. Haemophilus influenza, Haemophilus para-influenza. Anaerobic bacteria, Peptostreptococcus. Other Chlamydophila pneumoniae, Chlamydophila psittaci, Chlamydia trachomatis, Legionella. Pneumophila, Mycoplasma pneumoniae, Mycoplasma hominis, Ureaplasma ureolyticum. Levofloxacin has been shown to be active against Bacillus anthracis in vitro. Pharmacokinetics. Levofloxacin is rapidly and almost completely absorbed with absolute bioavailability of 99% following oral use, with peak plasma concentrations achieved within 1 to 2 hours of a dose. The mean volume of distribution of levofloxacin ranges from 74 to 112 liter after single or multiple 500 mg or 750 mg doses, indicating distribution into body tissues including the bronchial mucosa and lungs, but penetration into cerebrospinal fluid is relatively poor. Levofloxacin is approximately 24 to 38% bound to plasma proteins. It is only metabolized to a small degree to inactive metabolites. The elimination half-life of levofloxacin is 6 to 8 hours, although this may be prolonged in patients with RENA impairment. Approximately 87% of an administered dose was recovered as unchanged drug in urine within 48 hours, whereas less than 4% of the dose was recovered in feces in 72 hours and less than 5% of an administered dose is recovered in the urine. It is not removed by hemodialysis or peritoneal dialysis. Special population renal insufficiency. Clearance of levofloxacin is substantially reduced and plasma elimination half-life is substantially prolonged in patients with impaired renal function. Creatinine clearance less than 50 ml per minute. Requiring dosage adjustment in such patients to avoid accumulation. Neither hemodialysis nor continuous ambulatory peritoneal dialysis is effective in removal of levofloxacin from the body, indicating that supplemental doses of levofloxacin are not required following hemodialysis or continuous ambulatory peritoneal dialysis. Pronounce. Therapeutic indications. Levofloxacin is indicated for the treatment of adults, greater than 18 years of age, with mild, moderate, and severe infections caused by susceptible strains of the designated microorganisms in the conditions listed below. Acute bacterial sinusitis, acute bacterial exacerbation of chronic bronchitis. Community-acquired pneumonia and nosocomial pneumonia. Complicated skin and skin structure infections. Uncomplicated skin and skin structure infections. Chronic bacterial prostatitis. Complicated urinary tract infections. Uncomplicated urinary tract infections. Acute pyelonephritis, inhalational anthrax, post-exposure plague. Dosage and administration. Levofloxacin tablets 250 mg, 500 mg, and 750 mg administered orally every 24 hours. The dosage depends on the types and severity of the infections and sensitivity of presumed causative pathogens. Levofloxacin should be swallowed without crushing and with sufficient amount of liquid. Levofloxacin tablet can be administered without regard to food. Antacids containing magnesium, aluminum, as well as sucralfate, metal cations such as iron, and multivitamin preparations with zinc and or didenosine chewable tablets or the pediatric powder for oral solution. The dosage guideline as per the infection are given as under. Dosage in adult patients with normal renal function. Creatinine clearance greater and equal to 50 ml per minute. For acute bacterial sinusitis, 500 mg given for 10 to 14 days and 750 mg for 5 days. For acute bacterial exacerbation of chronic bronchitis, 250 mg to 500 mg for 7 days. For community-acquired pneumonia, 500 mg given for 10 to 14 days and 750 mg for 5 days. For nosocomial pneumonia, 750 mg given for 7 to 14 days. For uncomplicated skin and skin soft tissue infections, 500 mg given for 7 to 10 days. For complicated skin and soft tissue infections, 750 mg given for 7 to 14 days. For uncomplicated urinary tract infections, 20 mg given for 3 days. For complicated urinary tract infections, 250 mg given for 10 days and 750 mg for 5 days. For acute pyelonephritis, 250 mg given for 10 days and 750 mg for 5 days. For chronic bacterial prostatitis, 500 mg given for 28 days. For inhalational anthrax post-exposure, 500 mg given for 60 days. Plague, adult and pediatric patients greater than 50 kg weight, 500 mg given for 10 to 14 days. Dosage in adult patients with impaired renal function. Creatinine clearance less than 50 ml per minute. Dosage in normal renal functions every 24 hours. 750 mg in 24 hours, 500 mg in 24 hours. 250 mg in 24 hours. Dosage for creatinine clearance 20 to 49 ml per minute. 750 mg in every 48 hours. 500 mg initial dose, then 250 mg every 24 hours. No dose adjustment required for 250 mg. Dosage for creatinine clearance 10 to 19 ml per minute. 750 mg initial dose, then 500 mg every 48 hours. 500 mg initial dose, then 250 mg every 48 hours. 250 mg 48 hours. If treating uncomplicated UTI, then no dose adjustment is required. Hemodialysis or chronic ambulatory peritoneal dialysis. 750 mg initial dose, then 500 mg every 48 hours. 500 mg initial dose, then 250 mg every 48 hours. No information on dosing adjustment is available. Dosage in pediatric patients greater than and equal to 6 months of age. Type of infection. 1. Inhalational anthrax post-exposure. For pediatric patients greater than 50 kg, dose given 500 mg every 24 hours for 60 days. For pediatric patients less than 50 kg and greater than and equal to 6 months of age, dose given 8 mg per kilogram every 24 hours for 60 days. 2. Plague for pediatric patients greater than 50 kg, dose given 500 mg every 24 hours for 10 to 14 days. For pediatric patients less than 50 kg and greater than and equal to 6 months of age, dose given 8 mg per kilogram every 12 hours for 10 to 14 days. Adverse reactions. Levofloxacin is usually well tolerated. However, following are the adverse effects reported during its therapy. Common: monaliascias, insomnia, headache, dizziness, diapnea, nausea, diarrhea, constipation. Abdominal pain, vomiting, dyspepsia, rash, pruritus, vaginitis, edema and chest pain. Less common: genital monaliascias, anemia, thrombocytopenia, granulocytopenia, allergic reaction, hyperglycemia, hypoglycemia, hyperkalemia, anxiety, agitation, confusion, depression, hallucination, nightmare, sleep disorder, anorexia, abnormal dreaming, tremor, convulsions, paresthesia, vertigo, hypertonia, hyperkinesias, abnormal gait, somnolence, syncope, epistaxis, cardiac arrest, palpitation, ventricular tachycardia, ventricular arrhythmia, phlebitis, gastritis, stomatitis, pancreatitis, esophagitis, gastroenteritis, glossitis, pseudomembranosus/C. difficile colitis, abnormal hepatic function, increased hepatic enzymes, increased alkaline phosphates, urticaria, arthralgia, tendinitis, myalgia, skeletal pain, abnormal renal function and acute renal failure. Contraindications. Levofloxacin is contraindicated in patient with a history of hypersensitivity to this drug and/or other quinolone antibacterial, children or growing adolescents. Warning: serious adverse reaction including tendinitis, tendon rupture, peripheral neuropathy, central nervous system effect and exacerbation of myasthenia gravis. Precautions. Tendinitis and tendon rupture. Fluoroquinolones, including levofloxacin, have been associated with an increased risk of tendinitis and tendon rupture in all ages. Tendinitis or tendon rupture can occur within hours or days of starting levofloxacin or as long as several months after completion of fluoroquinolone therapy. Discontinue levofloxacin immediately if the patient experiences pain, swelling, inflammation or rupture of a tendon. Patients should be advised to rest at the first sign of tendinitis or tendon rupture, and to contact their physician. Avoid levofloxacin in patients who have a history of tendon disorders or tendon rupture. Peripheral neuropathy. Sensory or sensoromotor axonal polyneuropathy has been reported in patients receiving fluoroquinolones, including levofloxacin, which can be rapid in its onset. Levofloxacin should be discontinued if the patient experiences symptoms of neuropathy. Avoid fluoroquinolones, including levofloxacin, in patients who have previously experienced peripheral neuropathy. Central nervous system effects. Fluoroquinolones, including levofloxacin, have been associated with an increased risk of central nervous system effects. Fluoroquinolones may also cause central nervous system stimulation. Suicidal thoughts and attempt of complete suicide may also occur, especially in patients with a medical history of depression, or an underlying risk factor for depression. If these reactions occur in patients receiving levofloxacin, discontinue levofloxacin and institute appropriate measures. Levofloxacin should be used with caution in patients with a known or suspected central nervous system disorder that may predispose them to seizures or lower the seizure threshold. Exacerbation of myasthenia gravis. Fluoroquinolones, including levofloxacin, have neuromuscular blocking activity and may exacerbate muscle weakness in patients with myasthenia gravis. Avoid levofloxacin in patients with a known history of myasthenia gravis. Other serious and sometimes fatal adverse reactions. Other serious and sometimes fatal adverse reactions have been reported rarely in patients receiving therapy with fluoroquinolones, including levofloxacin. Discontinue levofloxacin immediately at the first experience of skin rash, jaundice or any other sign of hypersensitivity and institute supportive measures. Hepatotoxicity. Severe hepatotoxicity, including acute hepatitis and fatal events, have been reported for patients treated with levofloxacin. Levofloxacin should be discontinued immediately if the patient develops signs and symptoms of hepatitis. Clostridium difficile-associated diarrhea. Clostridium difficile-associated diarrhea has been reported with use of nearly all antibacterial agents, including levofloxacin, and may range in severity from mild diarrhea to fatal colitis. If Clostridium difficile-associated diarrhea is suspected or confirmed, ongoing antibacterial use not directed against Clostridium difficile-associated diarrhea difficile may need to be discontinued. Appropriate fluid and electrolyte management, protein supplementation, antibiotic treatment of Clostridium difficile-associated diarrhea difficile, and surgical evaluation should be instituted as clinically indicated. Blood glucose disturbances. Disturbances of blood glucose, including symptomatic hyper- and hypoglycemia, have been reported with levofloxacin, usually in diabetic patients receiving concomitant treatment with an oral hypoglycemic agent or with insulin. In these patients, careful monitoring of blood glucose is recommended. Photosensitivity or phototoxicity. Moderate to severe photosensitivity or phototoxicity reactions can be associated with the use of fluoroquinolones after sun or ultraviolet light exposure. Therefore, excessive exposure to these sources of light should be avoided. Drug therapy should be discontinued if photosensitivity or phototoxicity occurs. Patients with G6-phosphate dehydrogenase deficiency. Patient with latent or actual defects in glucose-6-phosphate dehydrogenase activity may be prone to hemolytic reactants when treated with quinolone antibacterial agents, and so levofloxacin should be used with caution. Patients treated with vitamin K antagonists. Due to possible increase in coagulant tests, PT/INR, and/or bleeding in patients treated with levofloxacin in combination with a vitamin K antagonist, e.g. warfarin, coagulation tests should be monitored when these drugs are given concomitantly. QT interval prolongation. Caution should be taken when using fluoroquinolones, including levofloxacin, in patients with known risk factors for prolongation of the QT interval, such as, for example, congenital INQT syndrome. Concomitant use of drugs that are known to prolong the QT interval. Uncorrect electrolyte imbalance, e.g. hypokalemia, hypomagnesemia. Elderly and women cardiac disease, e.g. heart failure, myocardial infarction, bradycardia. Opiates in patients treated with levofloxacin. Determination of opiates in urine may give false positive results. It may be necessary to confirm positive opiate screens by more specific method. Hepatobiliary disorders. Patients should be advised to stop treatment and contact their doctor if signs and symptoms of hepatic disease develop, such as anorexia, jaundice, dark urine, pruritus, or tender abdomen. Renal insufficiency. Clearance of levofloxacin is substantially reduced and plasma elimination half-life is substantially prolonged in patients with impaired renal function. Creatinine clearance less than 50 ml per minute, requiring dosage adjustment in such patients to avoid accumulation. Neither hemodialysis nor continuous ambulatory peritoneal dialysis is effective in removal of levofloxacin from the body. Ambulatory peritoneal dialysis. Indicating that supplemental doses of levofloxacin are not required following hemodialysis or ambulatory peritoneal dialysis. Geriatric use. Caution should be used when prescribing levofloxacin to elderly patients, especially those on corticosteroids. Patients should be informed for the potential side effects and advised to discontinue levofloxacin and contact their healthcare provider if any symptoms of tendinitis or tendon rupture occur. Pregnancy. There are no adequate and well-controlled studies in pregnant women. Levofloxacin should be used during pregnancy only if the potential benefit justifies the potential risk to the fetus. Nursing mothers. Because of the potential for serious adverse reactions from levofloxacin in nursing infants, a decision should be made whether to discontinue nursing or to discontinue the drug. Taking into account the importance of the drug to the mother. Drug interactions. Antacids, sucralfate, metal cations, multivitamins, concurrent administration of levofloxacin with antacids containing magnesium, or aluminium, as well as sucralfate metal cations such as iron and multivitamin preparations with zinc or didenosine may interfere with the gastrointestinal absorption of levofloxacin, resulting in systemic levels considerably lower than desired. These agents should be taken at least 2 hours before or 2 hours after levofloxacin administration. Theophylline, fenbufen or similar nonsteroidal anti-inflammatory drugs. Pronounced lowering of the cerebral seizure threshold may occur when quinolones are given concurrently with theophylline, nonsteroidal anti-inflammatory drugs, or other agents which lower the seizure threshold. Levofloxacin concentrations were about 13% higher in the presence of tenbufen than when administered alone. Probenecid and cimetidine. Caution should be exercised when levofloxacin is co-administered with drugs that affect the tubular renal secretions such as probenecid and cimetidine, especially in renally impaired patients. Cyclospon, the half-life of cyclosporin was increased by 33% when co-administered with levofloxacin. Warfarin, there have been reports in patients that levofloxacin enhances the effects of warfarin. Prothrombin time, international normalized ratio, INR, or other soluble anticoagulation tests should be closely monitored if levofloxacin is administered concomitantly with warfarin. Patients should also be monitored for evidence of bleeding. Overdosage. In the event of overdose, symptomatic treatment should be implemented. Electrocardiogram monitoring should be undertaken, because of the possibility of QT interval prolongation. Antacids may be used for protection of gastric mucosa. Hemodialysis, including peritoneal dialysis and ambulatory peritoneal dialysis, are not effective in removing levofloxacin from the body. No specific antidote exists. Storage: store at 25 degrees centigrade, excursions permitted between 15 degrees centigrade 30 degrees centigrade. Protect from sunlight and moisture. Thank you for watching. Please like and subscribe my channel. Thank you again.